Right.
Good evening, folks. If you're joining us right now, this is time for the People's Court. But this time, we want to look at a subject that is close to every single one of us. It's a matter of yours and my healthcare. Specifically, we want to look at what is the current state of the this thing that is devolved that we call healthcare. And tonight we have people here who are experts and stakeholders in this particular sector, and they're here to help us with their insight and with their views for us to understand exactly what is happening. And indeed, as it's raining out there, to find out where the rain started to beat us and perhaps where we can buy an umbrella, if at all.
Well, if at all, we're going to say that perhaps it's all done and dusted and maybe the health sector is not so good. Maybe that's the reason why we'll be asking where did it begin, bidding us. Allow us to introduce the guests that we have in studio. And right next to me, I would say, is Dr. Dennis Miskela. This one is always a tongue twister, Dr. and you know that, but at least we always try to get it right. Deputy Secretary General, that is the KMPDU. Thank you so much for creating time. That it was a mistake to devolve the health sector?
I don't think it was a mistake to devolve it, but it was a mistake to devolve it without structure or without unbundling the function and devolving the function and the funds. Yeah. All
right, we come back to that. Beatrice Kairu, health economist, and as well as Dr. Brian Lishenga, chairperson of the Rural and Urban Private Hospitals Association of Kenya. The last time we had them, we were talking about that shift from NHIF to SHA, and here we are. Do you suppose that it is aiding the devolved health sector in any way? I know Beatrice is going to say no, but Beatrice, what do you make of it?
Okay, thank you very much. It's not aiding because they did not involve the county government when making the decision to move from NHIF to SHA. Right. That's the first mistake this government ever did. And then on the other end, the structures in place to accommodate this new SHA was not put in place by the county governments. For example, like the primary healthcare services that the new SHA Act is actually advocating for, the county governments were not prepared. For example, empowerment of the healthcare workers within the county governments were not even empowered about this whole SHA process. For example, if it's I know the national government says it did the facility assessment to know what type of equipments are going to be needed within these county governments, but how much funding has been provided to actually enable these county governments to do that. Right. Then you look at the tangle between the county governments and the national government in terms of allocation of funds or disbursement of these funds. It takes delayment to the point you find even doctors or healthcare workers are actually not paid salaries. And you see human resource are the key because health services is more of operations. It's not like things like transport industry or agriculture industry. The main component is usually human resources, resources for health. Then on the other angle, we also look at when you look at the equalization fund, for example, that was actually put in the Constitution of Kenya, you look at that fund, how has it been managed, and how has that allocation of those equalization fund. Remember now, the political arena was coming to talk about 1 man, 1 vote, 1 shilling. You see, that is already destabilizing this whole process, saying that the equalization fund given to the marginalized communities is actually not being utilized to do what it was supposed to do. And healthcare was one of the areas marginalized counties were being brought to speed to be like other developed counties. But now you find the governors who are in charge, or the county managers who are in charge of these funds are actually redirecting those funds to other things that is not actually healthcare.
Interesting, and we were getting to that. Before we get to the other end, Dr. Brian Lishenga, your office cuts across all the counties, I would want to say. I do not know whether you were still holding this office before the health sector was devolved, or maybe you just got into it after that devolving of the health sector. What do you make of the performance of the health sector so far at that devolved level?
Well, I think we have to look at it as both opportunities and SWOT analysis, strengths, weaknesses, opportunities, threats. Yeah. And when we do a SWOT analysis, I think that there are some counties that are doing all they can to take advantage of the switch. Some counties like Murang'a County comes to mind, Makueni County, Kisumu County. There are a few counties which are doing the best. I will tell you, I am not one of those people who throws away the baby with the bathwater. I like to offer what we call structured criticism.
Right.
So one of the things that stands out very good, clear for me is the FIF Act, the Facility Improvement Fund Act, which for me is a major, major win. You can say what you want about the SHIF Act, about the other acts, but the Primary Healthcare Act and the FIF Act, what I think that the county governments need to do is to take advantage of this. Since 2000, level 2 facilities and level 3 facilities did not have bank accounts, did not have revenues. And this has been part of the explanation why primary healthcare in this country has suffered.
Okay.
Today, any governor who is forward thinking can open a bank account for his dispensary, his health center. They can start collecting some revenue, even if it is a little bit. And for me, that is a great opportunity. Where we are missing it is we are still caught in the idea that private sector and public sector in healthcare are competitors.
Okay.
For me, that is what we need to cure now and bring synergies.
And we'll be coming back to understand what the cure is. The other end, Victor?
Yes, actually, I like that. And I think what we've shared, we can go back and delve deeper into it a bit later. But we have some guests on the other side.
Right.
And I want to begin by introductions. Let's start with you, sir. How are you?
I'm fine.
Can you tell us who you are, where you're from, and what you do?
Thank you. I'm Jared Obonyo. I'm from Dagoretti North, Kawangware. I'm a health promoter, that is CHP. I've been in that for the last 5 years. So thank you for hosting me.
Karibu sana. Karibu Jared. What about you, sir?
Pleasure. My name is Alela.
You have the mic?
You can use the microphone. He's got one.
It's with Mom, eh?
Yeah.
All right. Yes.
Can we hear you? All right. Keep going.
Yes, my name is Alela, Chairperson, Nairobi Community Health Promoters, and I am here also to present the Nairobi views on matters health and devolution. And I'm pleased to be hosted once again here.
Karibu sana. Thank you so much. You say Mr. Adala? Adagala. Very good. How are you, madam?
Adagala.
I'm fine.
Karibu.
My name's...
We can hear you. Iko sawa. Yes.
My name's Catherine Jerry from Morem Ward, Embakasi West, Sub-County. I'm the County Secretary for the CHPs. I'm glad to be hosted here.
Karibu sana. And what about you, madam?
Good evening.
Good evening.
Yes, I'm pleased to be here.
Karibu.
My name is Aisha Hamisi. I'm a community health promoter from Kamkunji Sub-County.
Thank you very much.
I'm here to represent Kamkunji.
Karibu. And last but not least, our gentleman here.
My name is Roger Sogola. I am from Makadara, representing Jericho Lumumba CHPs. And what else?
That's good. And I think I'll start with you, Rogers, yeah?
Yes.
Rogers, were you a CHP before the launch of the big launch a few months ago? Were you doing that work before?
Yes, I was.
And for the time that you've done this work, from where you sit, where would you place the Kenyan health sector? Iko namna gani? Hali mahututi au mgonjwa wa kutembea?
Naweza sema at least sasa wamejaribu, kwa sababu mahali tumetoka ni mbali na mahali tuko sahi, mahali tumetoka ni mbali. And now that kuna levels za hizi hospitali, the services that zinaprovidiwa kwa hospitali, I guess wanajaribu kupeana ile matibabu kwa kila level. So like tuseme kama level 1, level 2, level 3, utapata kila level iko na inashughulika, iko na services zake. So unlike kitambo vile ningeona kulikuwa na backlog ya yes, ya cases za matibabu. And ilikuwa ni issue kubwa sana. So For now, at least hospitali zimekuwa mingi na pia tunaweza
kuna tofauti kidogo.
Kuna tofauti.
Okay, I'll come back to you. Obonyo,
yes.
You said you've been doing this for 5 years.
Yes.
Can you talk to me about the biggest changes in your sector? What are the biggest things you've seen changing in the 5 years that you've been doing this?
Thank you. I would say that for the last 5 years, I have seen, and you will allow me specifically not to talk about the national, but the county.
Please.
Because I do represent or work within Nairobi County.
Mm-hmm.
So start from zero. I would say there are changes in terms of structure. The level 2, level 1, as my colleagues have said, this is a little bit of change. And maybe I would give a thumb up to the current governor based on that. Because we've seen there are a number of the level 2, level 1 hospital, they are being put into place. The drugs, we used to have a lot of challenges. You would go to these dispensaries, you'd realize there's no drugs in those hospitals. Services were a little bit poor, which I can see there are changes. Now, the only problem that me currently am seeing within the short time we've had is to realize the government is bringing in new things. They're putting in new structure or issue like the SHA that we have. They're coming up with these things when to me, I think they're not prepared. There are some things they have not put in place. They have not done proper public participation or hear from people who live within those structures or the most affected, the most key players, the sick, the community people, even the workers within. They pop up one day and they're like, we want to move this hospital to this place without a good structure, good public participation or awareness. So we are happy. As a community health worker, I would say the government has tried in terms of health, but still they need to do more in terms of enlightening the community, in terms if they want to do a lot of some changes within the health sectors, they better engage the entire community or the stakeholders so that when they key in new things, we are able to shift and go into with the changes that are there.
I am curious on that note, briefly, Vic.
Sure.
I mean, when you say that the government needs to engage the people down there, just how crucial is the role of the CHPs in helping the government to achieve that?
Thank you. Briefly, like the SHA, let me deal with that briefly based on what they introduced.
Yeah.
Like CHPs, we have a gadgets and we do key in the household. So we were expected to help the community to register into SHA. Now we are like, I would say we have been sent to do that. But you realize we were not trained properly now to do it. So somebody tells you that install this app, go do this thing. At the same time, the app still has issues with internet. In a house, you can take like 2 hours dealing with one client. So how many people will you cover within a day? It's hectic. So what I'm saying is, I would wish within the roles that we have that we do engage. Sometimes this community, they're asking us, because we meet them regularly, what is SHA? How is it done? But you realize you are the first person who should explain to them deeply what it means, how it takes place, but you realize you are not party to it. Nobody has explained it well to you.
If I hear you well, and perhaps this should go to the Madam Secretary, am I trying to hear that perhaps maybe the CHPs could have saved us, if at all we are in the worst of states, could have saved us from plunging into this state of confusion? Because why would a CHP proceed to a house to try and train or even walk someone through the process of joining SHA if they are well clear that they have not understood the process themselves? You can take the mic behind.
Me, I can say, wacha tu niseme tu na Kiswahili.
Ni sawa.
Haya, kitu naweza sema imekuwa a challenge kwa CHP because unaona the government didn't do any public participation or sensitization even to the CHPs ourselves. So inakuwa ni vigumu because ukiangalia katika ile nyakati tuko ya mambo na ukienda hata kwa household unapata cause most of our household unapata ni watu wako chini. Haya, na sasa tuseme unataka kuregister wao wamekuwa na matumaini sana kwetu cause unaona wanakutegemea utawapima. Tuko na zile gadget tulipewa, tunawapima blood pressure, sugar level. Sasa unaona sasa umeenda tena na ile mambo ya SHA. We mwenyewe ujaelimishwa hao venye unaweza fanya nini kumregister. Iko tu na challenge cause kitu tulikuwa tunge request mi kama secretary. Kuna hiyo challenge if the CHP wangepewa nafasi wakalishwe chini wafundishwe the process, the benefit and the three structure of the SHA, ingekuwa ni vizuri. Cause saa hii most of the CHP hata wajui SHA ni nini, wako kwa giza. Unanielewa? Mimi kwa mfano unaenda unapata, kwa mfano niko kwa household fulani, client ananiuliza nikikuwa na shida tuseme labda ni surgery ama nahitaji labda radiology services, how much will I pay? Or inastahili nikuwe nimepeana nini ndio nikuwe kwa nini kwa ile mpangilio. Kwa hivyo mimi kitu ningeomba even to the county government and the national government, Ministry of Health, washikane. The first thing they could have done with SHA ni kusensitize the community. Alafu wa empower the CHPs cause wao ndio wako pale ground na wao ndio wanadeal na zile households. Unanielewa? Nikirudi kwa upande wa mipangilio ya kikazi, unapata CHPs ni watu ni kujitolea cause hata kuna watu hata unaweza shy kuambia mtu what you get at the end of the month cause it cannot sustain even a day kwa zile vitu unatumia. Cause unapata tuseme kama kwa hizo gadget tuko na hiyo ESH yenye tuna register nayo household, lazima simu ikuwe na data na hiyo data ni wewe ujiweke cause saile una synchronize iwezi tuma the data to the tuseme kwa sub county to the county level mpaka kwa Ministry of Health. Sasa kwa ile 2500 unaona tuseme kwa mfano kwa siku you have to tuseme yani simu yako ikuwe na almost 100 bob cause ndio uweze kuinstall cause hata ile kitambo tulikuwa tuna ile karatasi tulikuwa tunaandika referral cause most of our things tukiwa pale kwa community ni ku identify na ku refer. It's just like mapping, you identify na una refer cause sisi ni ile tu kama first aid tunapea kwa community cause most of the thing utafanya nini, lakini unapata zile kuna hiyo level 1 ya hospitali ile mi kama CHP na stahili kufanya nini kurifa, unapata most of the services kwa level 1 hakuna mambo na lab mambo na nini hakuna. It's just unaona tu kuna labda daktari tu akuja aone wagonjwa, most of na mingi hazina madawa tuambiane tu kweli. Na unaona hata kama CHP anajaribu unajaribu lakini hauna uwezo. Na most of the household unaenda kutembelea unapata kuna ile most of them living below the poverty line. Unapata saa ile labda unaenda kuangalia mgonjwa, we do follow up for defaulters of TB, ARTs lakini unaenda unapata mtu hata chakula hajapata, kwa hivyo atakumeza zile dawa inakuwa changamoto kwako. Sasa inabidi kama wewe ni CHP cause lazima ufanye follow up, ni client wako ana chakula, inabidi saa ingine hata wewe ndio utarudi kwa mfuko utafute venye atakula ndio aweze kuendelea na dawa cause ni ile kitu iko ndani yako. Unanielewa? Lakini inakuwa so challenging cause unapata maybe hata huyo client unataka afike hospitali
na hakuna njia yote.
Hakuna njia yote. Ako kwa household. Na inabidi sasa inatakiwa ujue venye atafika hospitali. Most of the CHP wanarudi kwa mifuko. Ndio ajue venye atafanya nini. We have the ambulances zenye ziko za county na zingine. Lakini unapata most of the time iko busy. Na unaona huyu mgonjwa anaweza kufia wapi?
Kwa nyumba.
So lazima unashughulika wewe mwenyewe.
Wewe ushughulike mwenyewe ujue venye.
Nafurahi sana umeangazia sana mambo mazito ambayo wewe mwenyewe unapitia kama CHP na wale wenzako ambao unasimamia kama chair lady. Naomba tuchukue break. To digest hicho kitu ambacho umesema, tufikirie mawili matatu. Tukirudi we will be able to talk to you and madam as well. Hujazungumza, tutasikia kutoka kwako. Lakini pia tuna maswali kwa wenzetu ambao wako hapa kwenye meza hii. We'll be right back after these messages. Please don't go away.
Vile unavyojua watoto wengi sana hawana namna. Mimi ningependelea watoto wasome.
I'm here to stress on education. At the same time, let us actually do any kind of sport that we are doing. Sport speaks the best language to everybody.
Tunataka tutafute talents. Zile raw talents kutoka kule nyumbani mashinani mahali tuko leo.
Hizi mbio za Chepsaita, like all other sports, zinaleta watu pamoja.
We want to use this event to uplift the lives of the community.
Anafurahia hii mchezo sana. Hata sikaange naambianga watu tuende Chepsaita.
Wanafunzi wakimbie ili wakuze talanta ya mbio ama kuhimiza tena elimu.
This is the place to be. Hapa ndipo mahali wanastahili kuwa tarehe 7. Wale watoto walikimbia last year, wamekimbia mpaka wamefuka mipaka zetu za Kenya.
Hey there friends, welcome to Kids on the Block, where fun and imagination come alive. We dive into magical world filled with exciting adventures and awesome friends.
What position were you in?
I was number 2.
What position were you?
Number 1.
He decided to cross the bridge by his house and look for food on the other side.
We're going to do half cup of chocolate chips, and the other one, we're going to do half cup of the blueberries.
So, grab your imagination hats and get ready to explore with us. Join us every Saturday at 9 a.m. for new friends, amazing stories, and tons of laughter.
Join us as we explore the journeys of those who defy the odds and break barriers. We dive deep into the stories of triumph.
Sometimes when parenting a child with a special need or whatever disability, family life becomes a bit complicated and you may end up raising the child on your own.
Here, we inspire.
I have a farm which one we showcase with other dyslexic youths and autism, how to farm.
Motivate.
It's never easy, but what we do, the best thing is to work with another parent who has an elder child than yours.
And break through the barriers one story at a time. Push your boundaries beyond the limit. Saturdays at 8 p.m. The Grind, where business meets brilliance.
All right, we're back and we're talking about the state of healthcare which is devolved in the country. I have a question for you, Beatrice, and it's come up from what has come from the other side. Devolution of healthcare was supposed to bring services closer to the people. That was the dream. But exactly, yeah. But it looks like from what we're hearing, it looks like it's resulted in fragmented governance.
Yeah.
So, from an economic standpoint, what key structural inefficiencies are stopping effective healthcare delivery at the county level?
First and foremost, for example, is the budgeting process. For example, so when you look at the budgeting process that goes to budgeting for healthcare services at the county level, you find that instead of it being done through evidence of data, data that has been collected, you find it's more political. And number two, we also now have the angle of donors who come and lobby. For example, if I am a donor who is focusing on HIV/AIDS, I will lobby, and then you'll find when they do the budgeting process, HIV/AIDS may be given a priority, and maybe that community is suffering from diabetes or suffering from another condition. Now, when you look at the budgeting process that is actually done within the county government, the community is never involved to participate. So actually what is supposed to happen, the MCAs, you see there are those representatives of the wards are supposed to call the community members and tell them, this is what we are budgeting for the healthcare services in the coming year. This is the plan. This is what we want to budget. So the community is supposed to give its input and say, for example, as we are suffering maybe from eye conditions or we are suffering from this the most, the community are the ones who are able to do that. Now, because that is not in place, you'll find what is prioritized may not be actually what the community actually needs, and there'll be a gap out of it. Then when you look also at the aspect of when these budgets are made, the allocation is made from historical data. It's not based on MND that was done. For example, the budget that was there in the, let's say, 2022 to 2023, every year, what is supposed to happen, the county government is supposed to do what we call an annual forum. They are able to see, based on what we planned and based on what we budget and what we have done expenditure, does it correlate? Did the resources go to the right place? Was the resources utilized the way it was supposed to be utilized? But that accountability is never there. When you look even at the M&D departments within the county governments, they're usually very underfunded. You even find it's only one person allocated to the Ministry of Health or the Department of Health. When you look at the research department that's supposed to collect this data, get information from these individuals. For example, these are community healthcare workers that have been brought on board, okay? Then the national government says the spend that is adequate for them is 2,500 shillings, for example. And this one is done maybe through a conditional grant, which maybe if you employ these CHVs, the national government will do one to three. Those conditional grants that are given to counties. But to be honest, is 2,500 shillings given to one community promoter adequate enough, looking at the conditions and the circumstances these individuals are in? Number two, the county governments, when you look at their budgets, none of them have put in place a budget to actually accommodate community health promoters. I don't even want to touch about other healthcare providers. So basing on that aspect, you find that the leadership, in essence, does not actually participate with the community. It's about there's a disparity when it comes to communication between the national government, the county government, and the people.
Let us be reminded briefly, on that very note.
Yeah.
That initially the community health promoters will tell you that they never used to be paid.
Very true.
This payment began just so recent.
Yeah.
And perhaps it was a plus just to appreciate the fact that, well, you have been doing this and for a long time. It's time that we appreciate you.
Yes.
Is it not too early to begin saying that, well, this is probably not enough? Because then at least, you know, it comes from a point where the government, the president says, you know what, it's important that we appreciate the work that you've done.
Yeah.
Let us begin by giving you this amount of money.
Yeah.
Let us begin by giving you at least 6,000 bob, you know, in a month. I mean, are we not hitting too hard?
We have to hit it very hard because look at the time consumed. You see, I hate us doing budgeting based on guesswork. That's a problem we've had with this country. Even budgeting for healthcare for a very long time has been out of guesswork. Now we are tasking. We have competent people within our Kenyan setting who can actually do the mathematics. But because we are lazy, we don't want to do the work. Okay. So that at least we start from a point of knowledge, from a point of information, from a point of understanding. Because like I've listened to them, when you spend 2 hours in one household, this individual, you cannot tell me in a month, okay, you're saying it's 6,000, but you see, if you ask them, they get 2,500. In a whole month, do you think 2,500, that person can depend on that amount of money in a month? Not possible. Number two.
Hold it there, so that we're fair enough.
That's okay.
Where did the rain begin hitting us? If at all, we feel like we are being rained on, and a proper one.
Thank you very much. And I'd like to give a brief history about UHC. UHC is Universal Health Coverage. So in 1978 in Kazakhstan, in a city called Alma-Ata, countries met in a program, a seminar, that WHO and UNICEF came together, and they thought about that we should push for health as an agenda globally in the political space, that it should be health for all. That it's unacceptable to have health inequity where in one country people can live to 100 years, in another country children die at 3 years. Okay. So there are steps that are put to place to ensure that people are able to receive that health care for all. And the gist and the firmness on the role of what the primary health care plays and what the CHPs do was really, really pushed at that level. And then come to Kenya, then we decided to devolve healthcare because, of course, the governors were like,
we have to have some sort of role to play in this devolution, yeah? And there were clear laws that were put in place to ensure that the devolution of healthcare was going to be very successful. There was the transitional authority that was supposed to devolve the function, not in 47 counties, but per county. We see one county does it, then the next one comes on board and all that.
Okay.
There were laws that were put in place, like the Schedule 4 around the role of labor standards being a national function, the role about policy being a national function, the role about training. There's some level of standardization that's supposed to do at the Ministry of Health level. Then come 2013, and what do the governors under the COG chair back then, the Isaac Ruto say? That no, you are fighting devolution by delaying all this piecemeal devolution. Give it to us, all of it. And the former president, Uhuru, says, okay, you want it, take it. Nobody even took time to cost that as we send the workers down to the counties, what's the value of the HR function, human resource function? What's the value of the drugs? What's the value of the building? Because they are building blocks to healthcare. Healthcare stands on 4 pillars. There are the drugs, there's the healthcare worker, there's the data and technology around information and all that. Then there is the financing, that all these things somebody must pay for them. But once you put those 4 legs, you hold them together under leadership and governance. That would be proper leadership. So when they don't cost these functions, they were given a function without unbundling the costs. So then they find that, no, we thought that this healthcare is a lucrative business, will be swimming in money. Only to find that there's so much money needed instead for them to invest, which they're not ready to do. Instead, the little money we are getting from NHIF reimbursing from the patient care, that's using to buy iPads and take MCS to Maldives to benchmark. You get that? So they're not plowing the little being made and not bringing more inside. That's the first challenge that we found ourselves in. Secondly, is then that the president, Ruto, comes into place and he sees the mess that is there in this healthcare. And he's like, maybe in the UDA manifesto, you can do something about it. And he puts a very clear messaging that he wants UHC to work, he'll put SHA. Those who didn't read the UDA manifesto, too bad for them. There was the issue about SHA and how to finance it was there. Because people think that when Article 43 takes about healthcare is a right for all, people think that it's free. There's no free healthcare. Somebody must pay for that healthcare, either through your taxes or through insurance privately or through the social insurance scheme, or through donors. Somebody must pay for that healthcare. In this country, we didn't take a chance to ask ourselves, how do we want to fund healthcare? So that when the president talks about social health insurance scheme, people didn't know what it meant. It meant exactly what we are now complaining about. But there lies the problem that in Kenya, in our country, we only have 20% of people on a salary. 80% are Juakali people. Yeah? We ask them that, how will you make these Juakali people pay this insurance? That's what was killing NHIF. Why? Because somebody is supposed to pay 500 shillings per month. He does not pay. Then one day he's riding his border and he falls down and breaks his leg. Then he goes and pays for 2 years. He pays 6,000 shillings, all for 1 year. But the treatment for this fracture, he broken limb, will cost 100,000. So then you end up with something called adverse selection, where uko na gari ujaweka insurance, ukishagonga ndio unalipa insurance. Unaelewa? So that was the problem. And we asked them that, why can't we go the easier way route? And this is the easier way route. If you come from Germany where 80% are on a salary, you can go through this shift thing because you are able to target the salaries. But if you come to Kenya where only 20% of people are, you're going to burden the few people who are working. And the same is Kela, who's going to pay for this 2.75. I have to pay for my mother and my sister who's jobless. So you're burdening me 3 times. So we told them that, why can't we do a tax-funded scheme where everybody buys sugar in this country?
Yeah.
Take a shilling or 2 off the 2 kg of sugar price and fund healthcare. Everybody uses some form of transportation. Take 3 shillings from fuel and fund healthcare. How come you are funding security through taxes? We have never gone to any war in this country and we are funding defense in billions. How come you are funding education through taxes? But when it comes to healthcare, no taxes. You want to do it through SHA. But even I know somebody will challenge me somewhere in government that no, there are 3 funds. Yes, the Social Health Act has 3 funds. Primary Healthcare Fund, the Emergency and Critical Illness Fund, and the SHIF, the Social Health Insurance Fund. These 3 funds, only the SHIF is contributory, yes. But look at the amount they are allocated for the Primary Healthcare Fund and the emergency illnesses. It's literally a drop in the ocean. And why? Because we live in a country where we don't make decisions by listening to professionals. As KMPDU, we sat with government, we have a 25-page document where we told them all the issues they need to fix. but they don't listen. And as long as they don't listen, SHA shift will fail, UHC will fail. Yet sadly, I can confidently say today that the only project that President William Ruto will do successfully or leave as a legacy is give Kenyans a UHC. If he fails on that, nothing else will work. And Kenyans are looking up. You've heard the sad stories our brothers are saying.
Yeah.
So no matter what kind of PR hashtags we put on social media, until that sick mother is able to get treated, until that father with hypertension can get their drugs, all this means nothing.
Jabba.
Yes.
Okay.
All right. That's a really good orientation. And I saw Dr. Lishenga nodding his head and smiling somewhat mischievously.
In agreement or no.
What were your thoughts when you heard this?
Can't tell.
I think that what we are hearing, because as an association, what we've been doing is surveying the country objectively to understand what is happening with the Social Health Authority, and this is what we are hearing. One, that primary health care has been ignored. And some of those things are what my colleague Ms. Keller is referring to. Just the budgetary allocation was insufficient. But that can catch up. I think that between him, all of us, if we lobby Parliament, we can move from 4.1 billion. Ideally, this thing has been budgeted, and we need 45 billion to actually provide primary health care for the population in a meaningful manner. But this is what we are hearing. We are hearing that level 2 and level 3 facilities where our CHPs are the first contact people, because they represent level 1. They don't have computers. They don't have internet. When power goes off, patient care stops. They close at 4:30. So, and then they don't work over the weekend. This is what we are hearing. So you can imagine, we have created a structure that says that you must go to level 2, level 3 before you are referred, let's say, to a level 4 or 5 or 6 facility. But on Saturday, your nearest level 2 is closed. Your nearest level 3 doesn't work after 4:30. They don't have internet connection. The training that has been happening since we transitioned has been a virtual training. We have, in fact, the feedback tells us that literally everyone in the health sector is saying, move the training from digital, come to us and train us on the ground, face-to-face, hands-on. Now, I want to give you imagine in Turkana, you are there at level 2 or level 3. Turkana is too far. Let's say Nairobi, huku chini huku. Okay? The training is happening somewhere. For your nurse to find her own transport or his own transport, to travel to go to where the training center is, or to use their own data bundles to log into a portal to train, we are dealing with fundamental challenges that we talked about them from the beginning. The other issue we are facing here is we are hearing the general public doesn't know. Like, what are you telling me? Proxy means testing. Mtu anaulizwa uko na ng'ombe ngapi? You have how many, is your house simiti or your roof, what? Then some of them, they think if they say good things, they will get. So they say, yeah, in fact, my house has tiles. Then here, the proxy means tells you 2,500 per month. The fella disappears. They cannot even want to pay that amount. So we have a sense of lack of knowledge in the public. They don't know what SHA is. They don't know what the benefits are. Our team here, when they go to the field, the SHA portal requires you to have very good internet speed. If you cannot have internet speed on your phone, you can't register. Some of the feedback we are getting is that when they register people, they never actually finish the registration. So this person actually comes to hospital, they are halfway through the registration, the OTP that was generated never came, it went to Jua. We have fundamental issues that need to be addressed. The beauty is every single person in government knows what the issues are.
So they are aware of the issues?
Every single person, I will tell you that they know what the issues are, they know the struggles these guys are going through.
So what's the problem then?
So what we require is a step back and a reprioritization as a country. You see, if you called the CEOs of the referral hospitals to this panel, they will tell you SHA is the best thing since sliced bread. Why? Why will the CEOs of level 6 and level 5 tell you SHA is the best thing? Because SHA is working for the bigger hospitals. You see, hospitals like Kenyatta National Hospital have had a local SHA office actually, literally, SHA transferred a branch into KNH.
Inside the hospital.
Inside the hospital. So they are getting real-time support. But your level 2 in Kakamega, your level 2 in Busia, your level 2 in Kilifi, in Kwale, they are not getting the same level of hand-holding so that they can transition. These gentlemen and ladies here, they do not even know what properly. I'm sorry, guys.
Is it true?
No, they need...
Talk to us.
They need... You see, when
we're coming back to you in a second.
Yes.
I'll come back to you, I promise you. When you listen to what is being said here, what goes through your mind? I saw you're scrunching your face, you're looking up in the air. Talk to me. What is going through your mind?
Thank you very much. Maybe to start off, I can say I've been a volunteer for long. So for one thing, I'll appreciate, since it was a passion, and I used to do it free of charge, and now at least the government is paying something. So sometimes it is good to realize the positive part of it. So the government brought in the gadgets, and the gadgets are working, but they really need a lot of maintenance, because like the BP machines and the glucometers, they need batteries. And there is also a place for charging. So if a house doesn't have electricity, you cannot continue doing the vitals. So you find that it has also brought in the issue of discovering diseases at the household level. And apart from maybe the positive things, you see like the CHPs, we deal with the raw data, and we also deal with the raw diseases. And as we deal with the raw diseases, as Daktari is saying, we have to refer them to the health facility. So we are the backbones of the health at the ground. So we are at risk, and we really need a lot of prevention, as the healthcare, as the primary healthcare itself is considered as for prevention and control.
I have a question on that point.
Yes.
Do you feel properly supported by the government that you volunteer for?
I feel we have some gaps, because you see, when they brought in the gadgets, they need a lot of maintenance.
Have you raised these concerns?
We have been talking about it, because we have been buying batteries for ourselves, because if you don't do it, you'll not have anything for the month, to report for the month.
I see.
You'll not be able to get data for the NCDs, diseases,
right.
and
you'll have nothing to report.
You have nothing to report.
So when you tell your supervisors, when you tell the people that you complain to that here are where the gaps are, here is where I feel the shoe is pinching me, what are you told?
They take our concern, they say they forward them, and they'll bring back to us the results.
And so far, have you seen any results?
We are still waiting. They say that the project is still at the crawling stage, so we have to wait. Maybe things will improve as time goes by.
Yeah.
Maybe just to comment on the SHA issue, you see already the itches, that app that we have. We also have that part of SHA. So like you see, when we do the registration at the community, we have a number of issues. Like where I'm residing, that is Kamkunji. We have a lot of migrants. And you see, like migrants, the SHA cannot register a migrant. They only take alien, but they cannot take that document of mandate. They cannot take Ugandans, Tanzanians. So you find that you cannot register them. And you see, these are the clients that we are dealing with. How do you leave a migrant who is sick so that you are not able to refer that client to the health facility? How will that client benefit? Or are we going to have a society that is sick because they cannot be able to be registered in a SHA? That's all those questions remain with us. And also another thing, you see, like registration for SHA.
Yeah.
When registering for SHA, you can register with any phone, even the small one, the Katululu. But when it comes to now transferring the SHA now into the SHIF, now when it comes to trying to link with the whole family and trying to make sure at least you take the photographs and everything. The phone cannot hold it. So you see, it is something that needs a laptop or a
tablet or something.
Tablet,
The more power and better.
More power and so many things. So we are left there. We wonder, we have the app with our phone. But there is nothing.
But your hands are tied. Adagala, I can see you nodding and shaking your head. Talk to us. What's your own experience on this before we come back to this table?
And even as you speak about that, you have the mic. I don't know whether your mic is on just yet. You could take one of them. Adagala, we all proceeded to Kericho County sometime last year, and the clarion call was Afya Mashinani. What do you make of Afya Mashinani?
Yeah, first, I love to say to the rest of the...
Is it? Yeah, just take the mic. Have the mic. Okay.
I have to say that the journey that we have journeyed since we started the community health work has never been an easy work. Having done or volunteered for over 10 years, until now that we now have promoters. Remember, we started as home-based caregivers. Now we are community health promoters. We have had community health workers, community health volunteers, and now community health promoters. We don't know what the next government will come to bring, but what I understand, that the issue that my colleagues have raised in terms of Afya Mashinani, in terms of what the work has been, it has not been easy. Fast forward, we have been in a system whereby we have been trying to help the government and the community. And for your information, we are the government. So when we do these things, we have to also understand that we also work to improve our own environment and our own health. Having said that, I'm on record because people think volunteers should not be paid. And I recall, even the UN has volunteers and they're living large. Why now Kenyan volunteers can be subjected to harsh condition in the name of volunteering? We have been on the forefront as primary healthcare providers, making sure that we have what it takes to bring the community or the persons that we are living with to the facilities. Way before there were issues of bedridden cases, whereby after now the intervention, they can now walk to the hospitals. The government of the day, and having progressively walked through the system of the government since independence, they were to fight ignorance, poverty, and diseases. But right now, for your information, he has talked something about funding the security sector. In my life, I've never seen a police station close. Police stations are open 24/7, but health centers close. At a certain time, saa 8 zimefungwa. Inamaanisha we give priorities where it don't belong. When we close a health facility near at a health level 1 or in a community, you mean when somebody is sick, the only way you can get assisted is either through the community health promoter or he or she is referred to Mama Lucy or Kenyatta or any other big hospital around that is operating within 24 hours, but it cannot also not hold. So primary health care is a way, even if we can dissect it in the world of the World Health Organization, through the community health and also the community health strategy. Community health workers or promoters are a huge resource. First, they were tagged with the Millennium Development Goals, and now the Sustainable Development Goals. And now Kenya is on verge of achieving the Vision 2030. But when you look at the progress that we are doing to achieve that, we are getting a road deal. Why? Because we understand if we want to come up with the preventive measures, with a good universal health coverage, we should invest more in preventive measures, not curative. We should not be in a position whereby we get sick and then we go to hospital to be treated. Why don't we devolve medicine, devolve workforce, devolve manpower to the community, to the level 1, whereby most of this ailment can be solved rather than getting to KNH or any other referral hospitals.
These are really critical questions you're raising.
Yes.
So much. I want us to take a short break, and when we come back, I want to address what you're talking about, and I also want us to talk about funding. I want to talk about 3 things. I'll talk about funding, and I know you come from the private health sector. Talk to us about some of the challenges you're facing.
Have they been paid?
Have you been paid the money that NHIF owed you? When we come back.
You hear 9 billion.
When we come
9
back.
billion is a lot of money.
It's a lot of money. You'll tell us how much it can do with your help, Beatrice. How much can 9 billion do? We'll be right back after these messages. Thank you.
Vile unavyojua watoto wengi sana hawana namna. Mimi ningependelea watoto wasome.
I'm here to stress on education. At the same time, let us actually do any kind of sport that we are doing. Sport speaks the best language to everybody.
Tunataka tutafute talents. Zile raw talents kutoka kule nyumbani mashinani mahali tuko leo.
Hizi mbio za Chepsaita, like all other sports, zinaleta watu pamoja.
We want to use this event to uplift the lives of the community.
Anafurahia hii mchezo sana. Hata sikaange naambianga watu tuende Chepsaita.
Wanafunzi wakimbie ili wakuze talanta ya mbio ama kuhimiza tena elimu.
This is the place to be. Hapa ndipo mahali wanastahili kuwa tarehe 7. Wale watoto walikimbia last year, wamekimbia mpaka wamefuka mipaka zetu za Kenya.
Hey there, friends. Welcome to Kids on the Block, where fun and imagination come alive. We dive into magical world filled with exciting adventures and awesome friends.
What position were you in?
I was number 2.
What position were you?
Number 1.
He decided to cross the bridge by his house and look for food on the other side.
We're going to do half cup of chocolate chips, and the other one, we're going to do half cup of the blueberries.
So, grab your imagination hats and get ready to explore with us. Join us every Saturday at 9 a.m. for new friends, amazing stories, and tons of laughter.
Join us as we explore the journeys of those who defy the odds and break barriers. We dive deep into the stories of triumph.
Sometimes when parenting a child with a special need or whatever disability, family life becomes a bit complicated and you may end up raising the child on your own.
Here, we inspire.
I have a farm which one we showcase with other dyslexic youths and autism how to farm.
Motivate.
It's never easy, but what we do, the best thing is to work with another parent who has an elder child than yours.
And break through the barriers one story at a time. Push your boundaries beyond the limit. Saturdays at 8 p.m. The Grind, where business meets brilliance. It's not just about the ideas.
I was working as a shampoo boy. I used to wash clients' hair on the sink.
It's about making them happen. From big wins.
In primary school, when we would be asked what people want to be, I was categorical that I want to be a nurse.
To hard lessons.
The consoles change, the gaming equipment keep changing.
We cover it all. Tune in to The Grind, where every episode is packed with insights.
The person who is serving customers, always be a customer-centric.
Strategies.
When
Welcome back. If you're joining us right now, this is the People's Court, and we're looking at the state of healthcare which is devolved in this country. Before we went on break, Mr. Adagala there was talking to us rather painfully, if I must say, about some of the challenges he's going through. And one of the things that came up from what you were saying, from what the two madams were saying, and from what Obonyo was saying, and from what you're saying earlier, is it's all got to do, well, a significant amount of it has got to do with money, how we fund healthcare. I have a question for the two of you.
Just
I want you to prepare this answer.
Okay.
You're the mathematical mind, so cook up some numbers. The question I want you to tell us is, in an ideal world, to fix the problems that we have, to look after them and the people they look after, how much would it cost to run healthcare properly for a year in Kenya? Okay? Think about that.
When you have to, that's why he said
Hold on. Just on average, how much do we actually need? Because one of the things you said earlier is that we're underfunding our healthcare.
No, we are overfunding.
We're overfunding.
Currently overfunding.
We're overfunding. So now I want you to tell us how much is needed, how much we're actually spending on it, and why there's a difference. All right? But Dr. Lishenga, just as she's cooking that up, and I want you have a different perspective on it, and I'd like you to share that. Talk to us about the private sector side. These guys are CHPs and CHVs, and they mainly refer people to government institutions, level 1 and level 2. But we've got another huge part of the community that can only or are only served by private healthcare institutions. Those are your people.
Yeah.
Talk to us about what you guys are going through right now.
Okay, so I mean, it's unfortunate that CHPs don't work with private hospitals, considering that CHPs are paid from taxpayers' money and private hospitals pay taxes. In fact, they should work more with us because public hospitals don't pay taxes. Okay. But so that is part of the disconnect, is creating two health systems. We need a single health system. But just to come to
you said that it looks like they're in competition.
There's always this idea that private hospitals are for profit, and therefore being for profit is a bad thing. But to be honest, if you've walked to any public hospital in this country, you will be asked to buy gloves, you will be asked to buy something, cotton wool, bring syringes. What is that if that is co-payment? You're also paying, it's just that it is hidden in a nice color that it looks like you're not. The reality of the matter is that we have a single health system. Even if I own a private hospital, I am licensed by KMPDC to offer services on behalf of the Ministry of Health. So therefore, I am just a contractee of the Ministry of Health. So we have a single health system. But I want to come to the issue of what is ailing us as private sector in terms of money, because we were on the money conversation.
Right.
So you've seen reports in the media that, and I keep seeing it, I think even yesterday there was a report that 2.5 billion is being released over this week. The debt was 19 billion. We have dramatically slashed it. This is part of PR. And this kind of PR is not healthy for the country. Before the SHA transition began, the Ministry of Health is on record as saying that the debt to the entire health system is 29 billion. There is nothing that has happened between 1st of October and today to reduce that debt from 29 billion to 19 billion. It is only being reduced on TV and in newspapers verbally. The way I can wake up tomorrow and say, hey, that 5,000 I owe you, it's now 3,000, something like that. Now, that is number one. Number two, the hue and cry that you are hearing in Kenya, which is making this show, is on out-of-pocket payment. Kenyans are still paying. When they go to hospital, they remove money from their pocket to pay. And where is the most of the payment happening? It is happening in outpatient. You go with a child who has a fever, they tell you, SHA haiko hapa, pay. So it is outpatient services. If the surveys we have done show that to a large extent, maternity is being done almost free. To a large extent, surgeries are going on almost seamlessly. To a large extent now, dialysis, you don't hear noise because dialysis authorization is almost seamless. But why do we still have noise? We still have noise because when you go for your regular outpatient, we don't have a system in the country. Now, what is the system supposed to be? It's supposed to be a capitation-based system. They said 900 bob per person per annum. Of course, we think 900 bob is a joke. We think it is too little. But we agree that if it is 900 bob for 56 million Kenyans, now we are talking. We can at least budget within that. But you see what is happening? It is 900 bob, but we're just going to give you 10% of it. That is where the problem is. Two, to this day, we are, which date is this? 18 or 19th of November. This is quarter number 2 of the year, which is October to December. No single healthcare facility in Kenya has received even 1 bob to treat an outpatient. None. Wherever it is, when you are walking to that hospital and you are expecting to get care for free, that hospital is yet to be paid for your outpatient service.
Contrary to what the government says, perhaps it's
totally
a challenge
contrary.
to us. It's a challenge to us to get into that investigative space.
Let's help us understand a little bit more.
The reality.
So where are you getting this money? How are you running your operations?
So we also have a survey. The survey shows that a third of hospitals, private hospitals and faith-based hospitals in Kenya are facing auctioning.
True.
67% of private hospitals and faith-based hospitals in Kenya cannot service their overdrafts.
And pay suppliers.
The banks have written to all of them. 75% of private and mission hospitals don't have gloves. They don't have cotton. So when you walk to that hospital and you are asked to pay out of pocket, it is because that hospital really has no other way to pay the nurses, to pay the doctors, to buy supplies.
The people that contract this hospital are not paying them.
Let me just finish with this and tell you. As we are here today, this night, SHA is sitting on a pile of money because your 2.75%, Miskela's 2.75%, Cairo's 2.75% has already hit the account. This is money like they have never seen since the Kenya was formed. This money needs to, I hope that nobody is looking at that money and saying, wow, jackpot. This is provider money. This money needs to leave those accounts and go directly to paying NHIF bills. You see, the government itself has refused to tell its ministries to release the money. They were deducting Akina Miskela money for 10 years without remitting it to NHIF. We have accepted. Now we are in a situation where we are going to use SHA money to pay NHIF debt. I hope that this money that has been collected will stream to facilities, so that facilities, public, private, and faith-based, they need this money to buy gloves, to buy drugs, to pay workers. That needs to happen.
All right,
recently, the NHIF, the SHA, the SHA boss was sent for compulsory. The CEO.
The
CEO. Yeah. So should we assume that the government is on alert to make sure that our money does not...
Time will tell.
Politics. Okay.
Beatrice,
For me, what I would
us.
like to say about...
How much do we need? Help us understand.
It varies. I don't want to be specific.
Okay.
It varies because healthcare is dynamic in essence, and you see, you do not plan to fall sick.
Can you give us a 10-year average? What have we been spending? And what
for example, for Ministry of Health, for example, the 2024-2025 budget was 127 billion.
Okay.
That is ministry national.
Okay.
And yet county government combined, they're given 400 billion. The county government revenue, 400. So Ministry of Health, which is not a county or what is it called? It's on its own, is already getting a third of what counties are getting. Yet who is providing the services? The county government, not even the national government. Already that there is a discrepancy in that aspect because county governments are the implementers, so they're asking why is so much money being retained at the Ministry of Health. That tells you the administrative cost that is actually being incurred in healthcare is overriding hiring doctors. What we really need is those providers providing, but a lot of money is going to administrative costs. And that was also the challenge that was happening with NHIF. Like almost 30% was going to administrative costs. That is too high. Actually, it should be reduced all the way to around 5%, so that most of the money goes to actually providing and delivering those services. Now, this SHA, on average annually, it's going to be getting...
If I may, I'm sorry.
Yeah.
On the point you just made, why are we spending so much on administrative costs?
Bureaucracy, bureaucracy. Wherever there is money, wherever there is a lot of money, we usually say it will attract criminals, it will attract crime, it will attract corruption. You get?
So
that
really-
is how, and that's what I wanted to highlight and say.
Please go
in
ahead.
this country, when it comes to the healthcare sector, we believe, we assume healthcare is sacred. But I want to burst your bubble and say, currently with this regime, we're experiencing what we call legalized corruption. By the establishment of SHA, they've already done what we call legalized corruption. Why am I saying legalized corruption? When you look at the Constitution, who should collect the revenue? Is KRA, right? Then they tell you the 2.75 they're deducting from your salary is not a tax. Yet it is based on your gross income. And today there was a ISPAC forum and they were asked that question. They fumbled, they did not want to say, like they were asking, why don't you tax our basic pay, but you're taxing our gross income, the 2.75. But when you look at how SHA has been established, they have opened bank accounts where now that's where the money is going. It is not going to the consolidated fund, which is supposed to be managed by Treasury and then disbursed. So it is going to 3 bank accounts, CDN, KCB, and whatever. That already is breeding ground for corruption because it will bypass Parliament. The chief contributions will bypass Parliament. The Auditor General themselves can actually not even see how that money was actually utilized and all that. Because were it going to the consolidated fund, then the Auditor General should actually audit. Then the other thing is that, so that whatever budget is made, it's subjected to Parliament. Whatever budget is allocated, it's subjected again to Parliament. Then against the amount of money, how it was utilized, it's able to be analyzed, engaged, whether was there wastage, was there corruption, and all those things. Now, SHA in its essence has already been separated. The contributions have been separated from the National Consolidated Fund. So I wanted to say annually, SHA will actually be collecting almost around 100 billion annually. That's a lot of money in its essence.
What can you do with 100 billion?
A lot. You can imagine how many cancer centers you can
Maybe
build.
Actually, the target is 300 billion.
The target is 300 billion.
And I think they will hit it in the next 2 or 3 years.
Wow.
300 billion it's more than our external
It should be a game changer.
It should be a game changer.
Actually, with 300 billion, we should just walk anywhere and walk out and get state of the art.
Now, Dr. Miskela, you were talking a little bit about even just the costing of you represent doctors and interns and all that. You're talking about how I know you still have something to say.
No problem.
But you're talking about just how flawed the system is in terms of costing the impact or the value of a single doctor in this country. Talk to us a little bit about that and what, for example, this 100 million that's being raised, what would that do and how would you split it if you were the Minister for Health or the principal policy and implementer of all the things that we've agreed upon? What would you do? Ideal setting.
You know, sometimes I really feel sorry for the president because the kind of incompetent people he has. You know, as a president, your work is just to be a vision bearer and give a broad statement that you want healthcare for all, afya kwa wote. I don't want to see any Kenya getting broke seeking healthcare. That's all you need to say, and everybody should be back in the room crunching numbers and thinking through how to ensure this happens. But the leadership and governance of healthcare in this country has failed. From those who cannot tell the governors that they are mismanaging healthcare in the counties, to those who cannot tell NHIF that they cannot spend 30% of their collections on trips and corner offices. Yeah? To those who can't tell that you have to hire people to run healthcare. Human resources must be there. There have to be workers in hospitals. You cannot, even if you hire 2 million CHPs and they go to the villages and pick up those illnesses and they take to closed hospitals. You have a dispenser with one nurse who, when she falls sick, they shut down. She's on maternity leave, she shuts down. She's going for visiting day for her child in school, it's shut down. Right now, there's a research that has shown that, you know, with the healthcare, there are only 3 things that kill patients. They're called the 3 delays. The first delay is a patient who has fallen sick reaching the hospital because there's a distance between them and the hospital. The second delay is that when this patient arrives to the hospital, finding a qualified healthcare worker to make a decision that this is malaria, this is what you're going to treat it with. At somebody, the third delay is that decision being made that now you need surgery, you need it. Those 3 delays. And how do you cure them? Right now, we have cured the first D that in every constituency, in every village, there's a dispensary or a health facility less 5 kilometers from it, be it private or public. So we have done a good job with infrastructure for obvious reasons that the kickbacks when you build them. You get that? They rather build them because they'll get the kickback. Then the second delay, now we have roads. We have motorcycles. People can be carried to access the hospital. Then when you get to the hospital finally, umepata accident pale kwa barabara, you thank God that umejipata kwa health center. You reach there, there's no doctor, there's no nurse, there's nothing. There's no healthcare worker in short. You start dying at that point.
Drugs are out of stock.
Then even the person you find there is not properly trained to make the right decision. There's no drug, there's no lab, there's nothing. So you have failed these people, and you've been telling them that if you have cured the HR function, the infrastructure bit of it. Number two, President said that he is fixing KEMSA and also increasing local manufacturing. Perfect job. We go to the third where we made the Digital Health Act and the agency. Now they're going to have data to make decisions. Why do I say data? Because I've just discovered, because I sit in the Presidential Task Force for human resource healthcare reforms, that we don't even have data for healthcare workers in this country. We don't know how many doctors, nurses we have, how many we are training, how many are leaving, no data. We don't have data on the drugs, on the hospitals where they are, zero. So finally, we have now fixed that. We're trying to now get the data to make decisions. If we use data to make decisions, even the strike we had for 56 days for interns, why do I say so? Because we spent 80 billion to cover costs for human resources for healthcare in this country. Interns cover for 30% of the HRH, human resources for healthcare. 30% of 80 billion is 26 billion. Yet the only money we are fighting over about this internship thing is 3.6 billion. For people doing work worth 26 billion, you can't just let them have the 3.6 billion because people don't think, they don't reason. Now they are fixed that the digital part of it. Now we have told them that can we be creative around the financing? And the financing is not so hard. In Abuja, we only ask for 15% of the budget. And just building a hospital like Kenyatta and putting all the beds would cost you around 10 billion, roughly. Yeah? So you can imagine if you had 300 billion that we're talking about here, what it can do. The problem with this country is that we have what we call budgeted corruption. That money, long before it arrives, kuna midomo inaingojea tu hivi. Yeah? And that's why you see the other day, I know that just this month alone, SHA collected 8 billion in 1 month. Even NHIF on their best days never went beyond 3 billion. So the money is there. But the Kenyans every day on the streets are asking that, hii pesa tunalipa. How comes we are not getting the services commensurate? I repeat again, no matter how many press conferences, how many hashtags the government sponsors, until Wanjiku Atieno cannot go and get care when they walk in. And no, CBC, we can say if you fail, you can go back to the old one. Remember, university funding, you can have a take two. Healthcare, when that patient dies because you failed them, that empty dinner chair is empty forever. There's no take two. Yet people play politics. Anybody who questions this, you're being told, no, you're a politician, you don't support government. We like the government to support it, but President Ruto must first of all fire the Minister of Health, whoever heads it. Because there's gross incompetence there. The shame that this share transition has brought to the government is clearly because some people somewhere refuse to listen to any form of reason.
Quickly, there's been preference for the private sector, you know, and despite the fact that, you know, people say it's expensive and all that. What is this that we can pick from them? And how can they come in to as well assist and, you know, address the strain, especially in the rural areas? Let
me tell you that 60% of Kenyans seek healthcare in private facilities. In fact, ile uchi ya serikali, the shame and the nakedness of how government has mismanaged healthcare is covered by these guys. But people have then, the Ministry of Health has then have like 2 children, like the main child and the stepchild, which is private sector. In every conversation that you have, nobody ever talks about how do we support the private sector. But more importantly, that Kenyans, there's a study I was reading, that Kenyans don't go to private hospitals because they have money to spend. Kenyans go to those private hospitals because when you go to public, bado utatumwa laboratory nje, ultrasound nje, dawa nje. So unasema instead of wasting time back and forth, niende private. I have to give you an example. Tonight there's a woman somewhere in Kawangware who mtoto wake akona fever. This woman is a mamafua somewhere in Kilimani. She asks herself that if I wake up in the morning and I go to a public hospital in Kenyatta, I'll have to queue the whole day. There will be no food for the others to eat when they come back. Or if I go do my 4 work and then go to the hospital, this child will be dead when I come back from my mama 4 job. These are the challenges every woman, every family wakes up every day wondering about. So that when the president colorfully says on TV that nobody will be paying anymore, and they go there and they find there's nothing, people get angry, and justifiably so. So we have to step up, and I really want to thank the role that private sector has stepped up. No, initially, in NHIF times, they were really comfortable for a long time.
Yeah.
During the Uhuru Kenyatta times, their monies were being paid on time and everything. But right now, they are up. And what I want to challenge the middle class, because I think the biggest problem in this country is the middle class. When the poor people are complaining, when I have a private medical cover, I will tell you that medical cover for 2 million inpatient, when you fall sick, will end the first week in ICU.
Right.
The next day, you'll cross to public hospital. So until we fix this mess, all of us, we will trouble. And as I finish, health is the only thing that we are all potential clients. I do say that we provide service. We also get those services. Everybody, if you're lucky, you'll die in your sleep. But either you'll fall sick or in some accident before you die. We must fix this. Even if you have the best cover, one day you're from Masai Mara on a holiday trip, you get an accident. The first place they'll take you is a public hospital, not a private hospital. So we must fix the public healthcare system, not for just ourselves, but for all those who cannot afford private too.
Well, fair enough. Gentlemen, let's allow you to say something before because we must speak progressively, and we must, give our very own opinions. We must as well advise where we can, much as we say that, well, there's stakeholder engagement that perhaps the government is not keen to, as well, just get to address some of these proposals that have been fronted to them. What do you make, progressively, what do we do moving forward?
Actually, what I can say is that at least for the government, let me quote Mr. Honorable Sakaja once said that in terms of funding the CHPs, that 1 billion shillings is a drop of water in the ocean. So I'm really worried as it comes that CHPs are really crying. There is no pay for them, or there is pay for them, but the pay delays. So what I would urge the Sakaja and the team is that at least tunajituma pale kwa pale mtaani na tuna work relentlessly. So aone vile tu atafanya mambo yake kama the governor of the county, na make sure CHPs wamepata pay on time, and then before tuende kwa barabara, unajua pia lazima tu pia maandamano kidogo ndio waone pia tuko serious. Naweza sema pia national stipend for the national our president at least azingatie national stipend na atimize. Alisema it's shilling for a shilling. So if kama Mr. Sakaja alitoa 35, inamaanisha pia yeye atatoa 35. But that's not all. We are not settled for 3,500 shillings. At least hii 35 aliipata kwa meza, but now the one that he really promised us, the 15,000 shillings, at least tunaweza kaa round table and then we talk about the 15,000 shillings. So after hapo ndio tunaweza leta zile malalamishi za hatuna kits, hatuna whatever the nini. CHPs wako pale wengi sana. So hiyo pesa ni kidogo. Nikisikia 400 billion shillings annually. 1 billion inaweza sustain CHPs.
And I'm sure the country appreciates so much of what it is that you do. So quickly as we come to a close, even as you, give your suggestions on what needs to be done, Jared, and then we take it round, coming to this side. And you notice one thing, Daktari, is that he speaks about Sakaja. There are counties that are getting it right. There are counties that are not getting it right. What is this discrepancy? To you, Jared.
Thank you. Generally, out of the view that we've had, even from the other technical team, what I would say, based on the finance, the main problem that we have is the people who are managing this money. The management of the money, as they have quoted it, when this money is out, people smile and people see it as an opportunity to loot. You realize the money is out, it should go to buy drugs, or it should pay the CHV. But you realize this person, or the person who is in charge of releasing the money, is calculating, if I take a month or two with this money, what can this money, in terms of the profit, What can I get out of it so that I get back the ile pesa yenye nilikuwa nilipe hao watu ikuwe imeniletea ka profit ndio ni release. So the management of the funds that are in the health sectors,
okay,
kuna shida.
All right.
And maybe as I finalize based on that, I'm sorry.
Yes.
I would really request, and me I've seen with the leaders that we have in terms of the CSS that are being appointed to manage the the ministries, if actually they can be put on book. I don't know, it was yesterday or today that the president talks of the scorecard of the leaders.
Right.
If they can be on the lookout, how they take time to manifest what they have and how they deliver that it is being checked every now and then. We are going to go better in terms of releasing the funds so that we get what we deserve to get.
Thank you, Mr. Obonyo. Thank you, everyone. I'm afraid the people in my ear are telling me we are completely out of time. Once again, we find ourselves with a subject that's bigger than the time that we have. But I would like to hope that all of us here have said something that is going to touch the people at home, that is going to touch the people in office, that we have tumesukuma gurudumu hatua 2-3 mbele. So I thank all of you for coming. Nashukuru sana for your views. Nashukuru sana kwa kuchukua muda wenu. I hope when we call you next time you'll come. Asanteni, and let's make Kenya better.
All right.
Thank you very much.
Let's be fair to the people who are watching back at home. And Steve Ogutu says, my view is that devolving health was a brilliant idea, but the big bang approach used by the government doesn't seem to work. That money is not following devolved functions, which then goes ahead to hurt the common mwananchi. And counties are struggling with the human resource aspect of health. HR aspect should revert back to the national government as it has the prerequisite mechanism to manage it. Well, we must close to that at that very point.
Absolutely.
All right.
Absolutely.
So, yes, like Victor says, this is beyond us. The conversation continues on our social media platforms. Always keep it TV46.